Good morning. I'm Prabhat Jha from the University of Toronto, and I'm pleased today to give you the key results from the World Bank's report called Healthy Longevity. Um, it corresponds to about 4 years of analytic work that looks at the nexus between healthy longevity, NCDs, and human capital. And I'll start by giving you the key messages. The first is that demographic challenges are a key headwind for human capital, and this involves the well-described uh, issues around lower fertility rates, older age distributions, which together will mean a lot more deaths among adults, paired with particularly rising burdens among women in terms of caregiving in particular, plus their own NCDs. NCDs are a threat to human capital and contribute to gender inequalities and poverty. Avoidable NCDs are targets of cost-effective and feasible interventions that we emphasize through a life cycle approach. And these interventions would increase human capital and raise productivity, as well as reducing inequalities. Effective action that accelerates performance to match that of top-tier countries could avoid about 25 million deaths by 2050 and meet all of the sustainable development goals, along with halving avoidable deaths. We argue that countries can lead healthy longevity initiatives with partnership from development finance and the creation globally of public goods to so-called bend the cost curve for NCDs. Well, the demographic changes that are occurring are well understood by this audience. And the key to note between 2023 and 2050 is that there will be about 1 billion more adults aged 15 to 69 and about 300 million more adults aged 70 to 79. The number of children 0 to 14 is projected to stay about the same. Along with these changes are a big change in the distribution of deaths, both the numbers of deaths rising from 61 million to 92 million from 2023 to 2050, but also a big shift in the age distribution at which they occur, the most prominent being a very large rise at deaths at age 70 to 79. Now, each of these deaths is accompanied by a large number of hospitalizations, and these NCDs that correspond to this are heavily concentrated in the poor, and they also create burdens in terms of caregiving for women at not just for childhood, which is well described, but also increasingly at older ages. NCDs are already the leading causes of death in pretty much every country, and by 2040, the proportion of deaths due to NCDs is to increase to about 90% across most countries. Now, in addition to NCDs affecting hundreds of millions of people, for example, depression, diabetes, cancers, all affect hundreds of millions of people. There are billions of people that have key risk factors for these NCDs, including approximately 7 billion with obesity, which is expected to double over by 2050. Heavy episodic drinking, about 1 billion or so exposed, 1.1 billion current smokers. And so these are targets for interventions. However, the annual global progress between at adult ages has been far slower than at ages 0 to 14. So this is a comparison of the rate of reduction between 1990 and 2019. And 0 to 14 age group saw 3.3% annual reduction. But the older age groups saw less than half of that as an annual reduction in the rates of progress. Now, this in part is related to the lack of relative tools for adult mortality reduction in contrast to children. And we've examined this by looking at the cost for saving a child's life in 1990 versus 2019, and the cost of saving adult lives at 15 to 49 and 50 to 69. And for children, it became cheaper, roughly from about $1,500 in PPP terms to save the life of a child in 1990 down to $800. In contrast, at 15 to 49, it was the slightly increasing cost, and there was a notable increase in the cost of saving an adult at 50 to 69. And this is a reflection of the substantial political commitment to child mortality paired with new tools, global public goods, delivery approaches that have come to bend the cost curve for child deaths but have yet to do so for adult deaths. And this is a key recommendation of the report is global public goods research to bend the cost curve so that it's cheaper to save the life of an adult in the future than it is now. One of the frameworks that we've established in the report is a reasonably simple one called avoidable mortality. And this comprises a simple metric comparing every country to the lowest age and sex mortality, age and sex specific mortality across a range of countries. So this is not model data, but it's actually comparing what is the lowest achievable mortality. And overall, about 7 in 10 of all deaths, about 40 million, could have been avoided in 2019 if all countries had the lowest observed mortality rates for each age and sex. Going forward, and you see that the proportion of those shown in the red is highest in sub-Saharan Africa. And that's a combination both of the prevalence of NCDs, but particularly of infectious disease targets. But nearly everywhere in the world, you see much more of the red or the darker shades of red and orange, meaning high levels of avoidability. It's lower in higher income countries, but in LMICs, there are still lots of avoidable deaths. We can turn this into a simple metric of the economic value of avoidable mortality. And the logic is pretty simple. People are willing to pay substantial amounts to avoid even small risks of death. And that's been shown in micro studies or in willingness to pay studies. And therefore, disease control yields large welfare benefits. The global estimate is that if all countries were able to achieve the performance of the top 20% of countries, the economic value would be about 19 million in terms of avoidable deaths. And this can be used to look retrospectively. So, for example, the 65 million child deaths that have been avoided approximately from 2000 to 2019 in LMICs equate to about 45 trillion in economic value as defined as a percentage of annual income. In Latin America countries such as in Colombia, the targets of avoidable mortality are shifting. In the green is shown where avoidable mortality could be achieved in 1990, and the big bulge is actually in adolescents and younger adults. But by 2030, you see that the major age group for which avoidable mortality could apply is going up to age 70. So even though the life years gained are smaller at older ages, they're still highly avoidable. And we see this also in studies that focus on specific diseases. For example, the contribution of vascular disease to NCDs is the leading contributor in terms of avoidable mortality. So across Asian populations of males and females, as shown in the orange, the percentage of annual income that could be gained from reducing NCDs is substantial, approaching about 20% across these countries. The approach to the HLI is a life course approach, and it argues for reductions in child mortality to continue, but to build upon those to reduce adult mortality right throughout the life course. And it takes a life course approach. And it's inspired by the ideas of Richard Dahl, who argued very eloquently, death in very old age is not avoidable, but death early in life should be rare, and death in middle age need not be common. And this, for example, compares the UK survival by age in 1960 to that in orange for 2010. And of course, everyone is dead by age 100, or almost everyone is dead. But you see the survival till age 80 has been substantially improved by about a decade. The report argues that what could be done is an ideal scenario is rectangularization of that survival curve till the ideal scenario. And paired with it would be a reduction in disability shown in the shaded part. So compression of mortality in middle age can lead to longer lifespans, but also reduction of disability in older ages. The interventions that are outlined in the Healthy Longevity Initiative are very much focused on priority cost-effective interventions that countries can select. It is not a top-down approach. It again suggests that countries can select from a menu of really cost-effective interventions. And the leading intervention of that is population-level health interventions, most importantly from higher taxes on tobacco, alcohol, and sugar-sweet beverages, but particularly on tobacco. And this can be delivered through strengthened primary care systems. involving district hospitals and substantially expanding the capacity of primary care systems with millions more doctors, millions more nurses, and more health clinics. It is paired with an approach that argues for building specific interventions that are supportive, such as social protection policies that leave people at older ages with some income support as well as health care. In addition, long-term care needs to move to community-based approaches that particularly lift the burden on women to provide long-term care. And finally, the approach is very much that the GPS of healthy longevity will be better country data systems, and this is urgently recommended in the report. The cost for the HLI package, which we consider a down payment on the overall improvement possible of reaching the top 20% of countries, is affordable overall. It's about 7% in all low and middle income countries, but in lowest income countries, it's 20% based on the 2050 projected public spending on health. So in those countries, foreign or ODA support would probably be needed. In addition to health interventions, the report argues for labor market strategies that facilitate longer and more productive lives, in particular pensions for the poorest. So this shows, for example, in India, the lowest education group not only have lower survival to older age, but very few of them on current strategies can expect to have a pension. So in this graph is only 6% of those with no schooling are lined up to have a pension, in contrast to about 58% of those with higher education. So social safety nets for older ages and long-term care are complementary strategies to the NCD interventions. Coming to the conclusions, the other approach is very much to use technical and simple dashboards of routinely collected data, which should be strengthened through improved statistical systems, including vital registration, to be able to track progress. And this is an example, for example, using India and Sierra Leone about what can be done in terms of a dashboard to measure progress and do comparative assessments across countries. In conclusion, I would like to submit that we have big challenges before us for the 21st century that are well described. Pandemics are very much been visible given what we had on COVID. Climate change is also quite visible. But demographic change in NCDs are as important in terms of potential threats to human capital, but receive far less attention. But for these, there are interventions that are possible. So the conclusions of the report are as follows. They're really in three areas. Adopt high-impact fiscal, public health, and clinical interventions urgently, including taxes, but also good primary care. Provide financial protection and address long-term care, and promote data and global public goods, including global public goods that improve healthy longevity. Thank you for your attention. I'd be happy to answer some questions during the follow-up phase. Thank you.